want to welcome NCB students and faculty, and especially students and faculty from other areas on campus. There are sign-up sheets over here on the table that you missed as you came in for Dr. Stetcher's BAMG 350 class, and also for Beta Alpha Psi and Professional County Association if you want to get professional hours for today's program. It's my privilege to introduce Dr. Randall Marsh. And I looked down through his list of schools and that. He's a Texas Tech University graduate with his bachelor's degree and his MD degree. He did an internship at Texas Tech University School of Medicine. His residency was at the University of Arizona School of Medicine, and a fellowship in cardiovascular disease at the University of Colorado School of Medicine. He's a cardiologist here in Greeley and Loveland, an employee of Cardiovascular Institute in Northern Colorado, Banner Health. He has an extensive list of organizations that he's currently on the board of directors or active in. Something for you to consider when you go out as professionals, not the medical organization, but in your particular field. He's on the board of directors of Weld County Medical Society, board of directors of the Colorado Medical Society, chair of the board of directors of the Colorado Foundation for Medical Care. This is the state quality improvement organization for Medicare and Medicaid. He's a member of the CMS Task Force on Healthcare Reform, and he's a member of the CMS Task Force on Patient Safety and Medical Liability Reform. In the last, since 1996, he tells me that he's spoke over 100 times on the future of healthcare. And today he's going to present a program on the new national health care bill, will it work? Dr. Marsh.
Can you hear? Does that work? Okay. Let's get to it. How many of you are in favor of financing delivery the United States public school system based on the principle of socialism? How many? So it's a minority. Same question. How many are in favor of financing delivery fire protection in the United States based on the principle of socialism? A few more, maybe close to half. Same question, the police. Almost probably more than half, it's interesting. And then healthcare. Very few. Okay, so the first trick is what is socialism? Is it a political theory? Is it an economic theory? Is it both? At least in my reading, I think you can construe it as both, but in terms of this talk, we're talking about the theory of socialism as it was originally written about, probably in the mid-1800s, which was the theory of economics. And in a nutshell, what socialism said is for the public good, you take all the money, you throw it in a pot, and you organize a central delivery system and financing to create the most efficient delivery of service for the public welfare. Hence, that is why we already do that with the public schools, fire protection, and police. We have already crossed that bridge, and it's important everybody understand that that is the economic principle behind the organization of public fire, public police, and public schools. That, in fact, is a kind of socialism. And the reason I start like this is I think it's important, everybody, to realize how socialism has been tortured in the vernacular, in the political arena, so that it is, at least when I was a kid, it was synonymous with being a communist. So we were accusing people of being communists while we were delivering these systems using their economic philosophy, that is socialism, or communism, if you will. So what's wrong with our healthcare system? If we're going to fix it, we got to know what's wrong with it. So to start that, we need to talk about what we're talking about. This is a business school, and you're business folks, so we're going to talk business. We're not going to talk much about health. We're going to talk business, money, and economics. What's your most valuable asset from the time you're born until the time you die? It's your health. Your most valuable asset in very real economic terms. Because once you lose any or all of that asset, your ability to compete, thrive, and excel becomes substantially compromised, if not fatally compromised. The flip side of that is what's the most expensive thing you've ever purchased while you're on this planet? And it's probably the same answer, it's your health care. And it's not so much what you pay for your health care as it is the indirect expense from the day you're born that your family pays and you pay all the way through your life for others. For every dollar that you pay on health care, you pay more than $1 for somebody else. And the number adds up over a lifetime. And maybe we could argue about food and we could argue about gas or buying a house, but I had my CPA run the numbers when I asked her this question, and she came back and said it's probably health care when you add direct and indirect expenses over an entire lifetime. And the next one is really cornerstone when you have a discussion about health care. Is health care an entitlement or a privilege? Should it be the same as buying a car if you can afford one? Or should we all be entitled to health care? We vote. How many people think health care is an entitlement? Gotta look at this. It's going to be less than that for sure. That's surprising. The older the audience, at least the less hands go up. The younger the audience, the more hands go up. A liberal-leaning audience, more hands. A more conservative audience, less hands. But it's less than half the room. So more than half of us think it is a privilege. Should it be both? Can it be both? How many think healthcare can be both a privilege and an entitlement at the same time? Okay. And the reason you probably vote like that as a majority is because that's what we have. We have a healthcare system, for some it is an entitlement, and for others they must pay for it. So the next question is, how much of our medical system is based on the principle of socialism? That is, just like the police and the fire, you're entitled to police protection and fire protection. What percent of today's healthcare system is based on that principle of entitlement? And my daughter can't say because she knows. Give me a number.
50%.
50%. A safe, perfect. He's got to be close to one or the other.
49.
49. Any of the young crowd have any idea what percent of today's healthcare system is already in entitlement? 60%. It's over half. How is that possible? You start ticking away all of the subgroups in the United States that get all or some of their health care subsidized by taxes. It starts to add up. College professors, firemen, policemen, retired school teachers, retired any government employee, all state, all local, all federal employees, active military, retired military, criminals. In this country, a father raper gets free health care. But the janitor down the hall may be paying taxes for that guy's health care, but he's not getting it himself. That's the lunacy of a schizophrenic healthcare system that's nobody's fault. It's just the way it happened. But it's over half of the United States gets health care subsidized or totally paid for by tax dollars, hence it's a socialized health care system. Who is entitled? I've already told you, government employees, retirees, et cetera, but there's also the Medicare and the Medicaid crowd. I give a lecture just on the history of Medicare and Medicaid. Where in the world did those things come from? That's quite a story. That is quite a story. Medicare is generally the over 65 crowd. And you're supposed to ask, why? Who came up with a law that entitles somebody 65 years or older to health care, but not 64 or 63? How did that ever come to pass? Also, if you have a disability and you're under 65, that came along later. So a 40-year-old who becomes permanently disabled qualifies eventually for Medicare. The Medicaid crowd has nothing to do with age and everything to do with economic status in the country. The poor, the disadvantaged, qualify for Medicaid. And both of these came to pass in the mid-60s. And it's really a fascinating story as to why we took almost 200 years to create one socialized health care plan. We fought tooth and nail for 20 years to get that one, and at the last minute, we got two. How did that happen? Well, that's also a great story. We don't have time for that. But the fact is, these are the arbitrary distinctions within the country who get socialized health care. And the next question is what is our moral obligation to do this? Where is it written in the Constitution that we are obligated to entitle a significant percentage of the country to health care? The answer is it's not in there. It comes under the implied powers, which is always subject to controversy, negotiation, and change. Is it fair to entitle only some while you make the rest pay for it? Remember, if this is the country and more than half the room is getting a health care either subsidized or totally free based on taxes, while the other half of the room is trying to buy their own and paying taxes for this side of it. And if you go back to the first slide or the second slide, we're talking about probably the most expensive thing you ever buy. Who would want to entitle a 4,000 square foot home to everybody in the country? Who would want to entitle 55% of the country to a 4,000 square foot home while the other half has to buy their house and pay taxes for this half to go get a house? Ludicrous. We wouldn't do it. Now, we do subsidize housing, but we don't subsidize 4,000 square foot homes for everybody. But in fact, this thing of health care is more expensive than that house. And that is the reality of today's healthcare system. We have a socialized, single-payer healthcare system for over half the country. So the activists out there who say we don't want socialized healthcare, we don't want single-payer medicine, they know not of what they speak. We're already there. And we burned the first bridge in 65 with Medicare and Medicaid. What other country does this? Nobody. Is the open-ended entitlement for this half of the room sustainable? And the key word is open-ended. There isn't a budget. We spend it, you pay. You spend more, you pay more. And that, in fact, is the second of the two biggest problems facing the United States healthcare system. And we have to fix both. Number one, you got to make it fair. This dichotomy, left alone, will tear the country apart. The haves and the have-nots. And the second thing we have to do is we have to figure out an economic principle upon which to make it sustainable. What is that? It's a budget. We as a country have got to figure out how much we can afford, and we have to live within that means. slide's 10 years old. The point of this slide is to show you what the rest of the Western world has decided. They have decided that there is a moral obligation to their population, and so that the vast majority, if not the entire population of these Western countries with which we share great common ground, even 10 years ago, had tax subsidies to finance their health care. Socialism in one sense of the word. And by the year 2000, we were at 45%, and now we're about 55%. So that shows you how we compare to the rest of the Western world. All right? Let's switch gears. We're just going to talk about the chosen few. Forget about the saps that pay for it and also pay taxes for these guys. All right? Does either public system actually pay the true cost of health care? Would it actually cost the hospital and the doctor? And the answer is generally no. So that right now we got a major problem with both of the functioning public health care systems, given the fact that neither one of them really do pay true cost. Medicaid is ridiculous. I probably get paid 20 cents on the dollar when I see somebody that's from Medicaid. And in some situations, I'll get paid 7 cents on the dollar. Medicare is better. I'll get paid 50 or 60 cents on the dollar for Medicare, which is close to cost. And if you're in the doctor's office, it won't meet the cost of that doctor's office. If you're in the hospital, generally Medicare for a big hospital, they can sort of break even, just barely, maybe not, depending on the kind of hospital that you're dealing with. But over an entire system, neither one of these pay true cost. Let's just talk about Medicaid for a second. Medicare is federal. All the money comes from the feds to finance the Medicare system. The Medicaid system was thrown in at the last minute as a political compromise to get conservatives on board, if you can believe that. Because the argument was the liberals wanted Medicare to extend not only to the 65 and over crowd, the liberals wanted Medicare to extend to the poor. And the conservatives said, no, that's too much of a tax hike, it won't work, we'll be against it. And so what they did was very clever. And politically, it was a masterpiece compromise. They said, okay, let's build a second system. Let's fund it only half federal. Let's have the states fund the other half. And here was the kicker. They don't have to. Voluntary. So Medicaid, in its original form, was a voluntary state participatory system for the poor. And at the beginning of Medicaid, there were 16 states that bought into it, and the rest did not. It was voluntary. Now they're all in. And it's still voluntary, but they're all in for a whole bunch of reasons. The point is, the states carry a substantial burden of the tax that funds Medicaid. Okay? How much of this state's budget goes to Medicaid? Any ideas? It's almost a fourth. 21, 22, 23%, depending on how you want to put the numbers up. Where does that money go? Where does 2/3 of that money go in the Medicaid program? Nursing home. So a huge chunk of the state budget every year goes to the custodial care of the elderly. And it's getting bigger every year. And that's one of the big fights after the health bill is passed, is whether or not the states are going to be able to shoulder the extra tax burden. And Schwarzenegger's already said, no. Ain't going to happen. The point is that the budgetary constraints on the states and the budgetary constraints on the federal government have now come front and center in the discussion of health care reform. What used to be $3 billion and now is $453 billion. Well, it's the cost of Medicare. The first year of Medicare is projected to be around $300 million. It came in at $3 billion. There was no Congressional Budget Office, the CBO, back in those days. There was no projected impact on the federal budget of the new Medicare and Medicaid program when they were passed in 1965 because Johnson wouldn't let them do it. Because he knew if the public saw the projected cost, it would never pass. Pretty smart guy, huh? Smart from the point of view of getting something done, but was he smart from the point of view of what's best for the country over the next 50 years? That's another discussion to have. And that cost keeps going up and up no matter what the feds do to try to control the cost of Medicare. We're going to talk about that in a minute. So in today's environment, neither of these systems are sustainable. We can't afford them. We cannot afford them as they are right now. And in that light, how much of this year's budget is actually paid for in the federal government? Anybody have any idea how much we're going to borrow this year to pay for this year's obligations? We've got about 60% of the budget paid for, the taxes that this government collects. So almost half of what we're going to pay for this year in the United States, we got to go borrow from somebody. Mainly China. Okay? And that piece of information is what made the discussion of the health bill so difficult. If you heard it once, you heard it a million times. It must not raise the deficit. The whole thing was predicated on being budget neutral or reducing the deficit. So before we get to the bill, let's be very clear. I have not said boo about the private insurance industry. I have not said boo about the uninsured. Because right now, they're not the problem. The problem is the entire public system, which is over half the system, doesn't pay costs. And the second problem is this half of the room is getting taken to the cleaners. And has been for a very long time. That's got to stop. That has got to stop. It is not fair. And if you're on the other side of the Atlantic looking over here, you shake your head and you go, how can the Americans, theoretically the most civilized country in the world, have such a nightmarish healthcare system? How can that come to pass? You break your leg in England, they take care of you. Want your gallbladder out in England, Holland, France, they do it. Over here, money gets in the way, unless you have health insurance. Big difference. And the toughest problem, whether it's the private or the public, we don't have a clue how to control costs. So if I've depressed everybody, I probably should depress everybody. This is hard, guys. Some say this is the hardest problem we've ever faced. And this country's faced some tough ones. Because there are really no good guys or bad guys in this fight. You can't say the North versus the South. We're all mixed in with each other. So you have to take this in terms of how do we do this for the best of all of us? And we have to reach some common ground if we're going to really solve the problem. Has anybody tried before? Sure they have. There's a whole lecture right there of the national attempts, including Wagner, Murray, and Dingell, which introduced their bill 13 years in a row. And they came close a couple of times to national health insurance during World War II. Close, but no cigar. Truman got close. What almost happened with Medicare, almost, was that it was voted in as a national health insurance plan for all of us. But then the liberals and the conservatives got to fighting over the tax burden, and what came out of that was the compromise and the new Medicaid program. One of the ironies of that compromise 50 some odd years later is now the budget of Medicaid is bigger than the budget of Medicare. So the share and the burden on the states has really escalated in the last few years, primarily because of custodial care. How much money do we put into custodial care in the United States? It is astounding. And we all know about First Lady's Clinton attempt, which was noble but naive. During all that time, here's another lecture on state attempts at reform. And all of these were tried and went by the wayside pretty much because they couldn't control costs. And some are still going, but they're shadows of what they were supposed to be. At one point, TennCare had 1/4 of Tennessee enrolled in that government-sponsored health care plan. Then it went bankrupt, and now there's like 15,000 people in TennCare. And Dirigo sort of went the same way. It's kind of funny. Dirigo's Latin means I lead, or to lead. Maybe if we have time, we'll come back and talk about the 208 Commission, which goes back to 2006, 2007. But the point is, there's a lot of history here. A lot of people have tried. They tried hard to fix this. All right. The new health care bill. Another attempt at what we call incremental reform. All these states try to keep the basic integrity of this insane system and tweak it to make it work. They all failed. And now we have a national attempt at the same time. So here we go. Who gets covered? A lot more get covered. 94% of us get covered. So now, the unfairness issue, a lot of that has gone away because a significant chunk of this side of the room now has subsidy for coverage or gets it for free. So in one fell swoop, the Democrats have attacked problem number one as best they can in this political climate. Not everybody gets it, but 94% is a lot better than where we are. And of course, will it be affordable? We'll come back and talk to that later. One of the things that happens in this immediately this year is the states are now told, mandated, to set up new high-risk pools for people on this side of the room who either cannot afford or cannot get health insurance. And so the states are now scrambling, trying to come up with these high-risk pools, and it's still not clear where the money's going to come from just to set up the pool. It takes a bureaucracy to do that. And it's key that everybody understands that we go step by step. Every new thing requires a government bureaucracy. And in fact, the Tea Party and the conservatives, a lot of their squawking is based on a dramatic increase in bureaucracy that it will take to do this. And they have a justifiable squawk. It's a lot of more new government. So we're going to have to wait and see in the next 6 months if we get high-risk pools, even in this state. And who's going to fund that bureaucracy? Is it the state or the feds? And will the new high-risk pool actually come up with something that's affordable? Pie in the sky, we don't know, but that's right off the bat to try to help people. A lot of this other coverage does not come to fruition until 2014. Okay? Who pays for the new coverage? Where does this money come from? 10% tax if you go to an indoor tanning salon. Where did that come from? But it's in the bill. Somebody got a bee in their bonnet and said, we're going to have a lot of skin cancer, we better tax them. So they did. And the tanning lobby isn't. There wasn't a pushback. Tanning lobby, those people don't have enough money for professional lobbyists, they just tax them. But it's in the bill. Democrats talk at great length about how this is a deficit reduction package. We're going to reduce the deficit. We'll go into that later on. But one of the ways they do that is they start stealing money from the existing public health care systems. Now, if you've heard anything about the first part of the lecture, you immediately, red flag's going to come up here and say, no, they don't pay cost now. How in the world are they going to take money out of those systems without bringing those systems to the needs? Well, the feds say the delivery systems have to get more economical, do more with less. And those are going to happen over the next 3 to 4 years. And it's not just the docs in the hospitals, it's home health care, it's hospice care, it's nursing homes. Dollars are going to be taken away to put over to this side of the room to help with subsidies. There will be lots of new taxes. You can go through the 2,700 pages and find it. Some are hidden. By 2014 or 15, if you deduct medical expenses off your income tax, it's probably going to go away. So your tax burden will go up because they took away your write-offs of your health care deductions. So it's a hidden tax, if you will. And that's not going to be big dollars, but there are going to be some people that are going to get a rude awakening when they see what their taxes do when they lose that deduction. We're going to talk about new fees, specifically on the drug industry and the device industry later on. What kind of coverage? What do these people get? What do half of them get? It's about 30-some-odd million people. What do half of those people get in this deal? Medicaid. Is that a great deal? It's insurance, but it pays so lousy, you're going to have a very tough time finding a private doctor to see you. Most of the Medicaid in this town goes to Sunrise. And those docs are salaried, and most of that is subsidized by state and federal money. Otherwise, Medicaid would have no place to go in this community. They just don't pay enough. So that, personally, it was a great disappointment when I found out that half of the new coverage was Medicaid. That's a huge problem with this new plan because it's almost self-defeating. Unfortunately, there's already said so. He's not alone. A lot of states are going to squawk. When this starts to come to fruition, the guys that wrote the bill, pretty smart people, they said, well, if we do it next year, it's going to be political disaster. So we'll gradually put us on the states about 2016, 2017. That's when it really gets them. So we got 4 or 5 years to wonder how the states are going to pay for this. And even if they can, will the Medicaid crowd be able to get coverage? Because now we're going to put 30-some-odd million people into the healthcare system who want healthcare. Do we have the people power to do that right now? All right? Oh, before I go there, let's talk about one other thing. The other half of the coverage here will be with the private insurance industry. And one of the deficits of this bill, one of the shortcomings of this bill, is it really doesn't define what the coverage will be. It leaves it sort of nebulous. So the question is, will this new federally subsidized private health insurance really have meat in it, or will it be a bare bones policy? We won't know in 2014. So when you hear people stand up and say, we have covered 94% of the country, yeah, but it's in the details. And what about cost control? Remember, that's part B of trying to save the system. They did fairness as best they could. They have increased coverage, as lousy as it may be to a lot of people, but can we control cost? Well, now you got to know some more history. How are we doing on time?
15 minutes.
How much?
15.
Left?
Yeah.
Oh, really? I've talked that long. Okay, all right, awesome. Medicare, they tried twice to control costs with Medicare, the DRGs and the SDRs. The DRGs are diagnosis-related groups, and what that means, in 1983, the hospitals were no longer allowed to send a bill to Medicare for what they did during hospitalization. They sent the hospitalization to Medicare, and Medicare said, okay, we're going to pay this much for that hospitalization. Medicare decided what it was going to pay. No longer fee-for-service. Big hit to the hospitals. They survived. They learned to live with diagnosis-related groups, but it really didn't bring down costs from 1983 up to the present. So the next thing they tried was the SGR, which is the, I forget what that acronym stands for, but what it is it's putting the kibosh to doctor's fees. And so what they said is that on sustained growth rate, that's what it stands for. This came about in the late 90s, and the Congress said, okay, the costs are way out of control. So every year that we spend too much money on Medicare, we're going to take 5% away from the docs. And they're supposed to start every year from about 1998 or 1999. It's happened one time. And the way the law was written is if the Congress didn't have the guts to take the money away from the docs, it rolled over to the next year. So if you didn't take the 5% in 2001, 2002, you now had to take 10% from the docs, or whatever that number was. Well, now it's up to 21% because over the past few years, Congress has not had the guts to take it away from the doctors. And now it is to the point of being stupid. The SGR was supposed to hit us last July. They have put new laws through Congress, both houses, and signed by the President 5 times, extending the deadline of the SGR, and now it's been extended to June 1st. So it's a joke. But it's a law they can't get around, and if they don't figure out how to fix this, you're going to knock 21% off the docs in one fell swoop. And then the Medicares will be just like the Medicaids in terms of trying to get private health care. It just ain't going to happen. And the Congress knows this. And originally, the SGR fix was supposed to be in the bill. But they took it out of the bill because it made it a deficit increasing bill. So in order to be able to stand up and say it doesn't increase the deficit, they took the problem out of the bill even though it's part of health care. Lunacy. That's what they did. They're the Congress. And in fact, the future of this plan can almost be summarized in what in the world they do to the SGR. If they can't fix this, we don't have a prayer for the whole big new plan. And so far, they got no ideas how to fix the SGR. What are they going to do with it? And I don't have a clue yet either. We'll see what happens June 1st. What they'll do is extend it again, which is what they've been doing for years and years. All right. There's very little written in the bill about how they're going to control costs. A few paragraphs out of 2,700 pages. But the real meat is the Independent Payment Advisory Board that has yet to be created. 15 people nominated by the President, confirmed by the Senate, 6-year terms, quasi like the Federal Reserve Board, to be free from political influence. That's why they're done that way. This is why the Federal Reserve Board is put together that way. I think the Fed has longer terms. Right. This is the so-called death penalty that the Tea Party activists are so much against. The power this panel will have is they will look at the budget every year for Medicare and Medicaid. And they will say, it's too much money, we have to cut something somewhere. So they will recommend to the Congress to take money away from this, or this. They have that power. And the Congress either votes it up, they can modify it, they can vote it down. Okay? If they don't act on it in 30 days, then the President can sign it into the law. And if they veto what the panel says, the President has the power to veto the veto. So this is the first attempt to control costs in a public health care system outside of quasi the legislature. They are taking some of the control away from the Congress in order to try to get a handle on costs. Why? The Congress can't do it. If the Congress was going to be able to control costs, they would have figured it out by now. They tried the DRGs, the SGR, they can't do it. So the guys that wrote the bill said we got to come up with another way of controlling costs. We're going to give it to a quasi-independent panel of experts free of political influence. It's almost like a fourth arm of government because it's such a big ticket item for the government. And the power these 15 people are going to have is enormous. And it's predicted this will be their full-time job. That's all they're going to do. And if they ask me to serve on it, I want nothing to do with it. For the private system, over on this side of the room, these new exchanges which don't exist yet, are theoretically supposed to bring competition into the private market. Will that work? Stay tuned. The individual mandates are very unfair because the mandate only applies to a third of this side of the room. This side of the room doesn't care, they already have it. The side of the people over here that already have employer-sponsored health care don't care, they already have it. It's the people that don't have health insurance, that can't afford health insurance, that's where the mandate gets hit. That is not fair. You are mandating something to a portion of the population and not everybody. And that may be the basis of the constitutional challenge of the individual mandate. So why do we have the mandates? You have to have the mandates, or you cannot tell the private insurance companies to insure everybody, which is what the bill does. The bill says you guys got to insure everybody. And the insurance company said, okay, but then everyone has to be made to buy it. And that's true. In the rest of the Western world, where there are individual mandates, people understand everyone has to buy into this thing if you're going to force a private company to give everybody a policy, no questions asked. There's no other way to do it. So there's a good reason for the mandates. It's just the way that they're applied is very difficult to swallow. And they may not be constitutional. All right? We'll come back to the drug companies in a minute. The employer mandate is a problem because theoretically this is going to hurt employers unless the cost comes down. If the cost doesn't come down, then the employers are going to be in trouble, even with the subsidies they get in the bill. And they do get some bill. So let's talk about the insurance industry. This is all the new rules for the insurance industry for controls. They have to insure everybody. They can't turn you down for pre-existing. They have to give you free preventative services. They cannot rescind your policy except for fraud. There's no more lifetime caps. There's no pre-existing conditions. There still isn't a standard benefit package, so they can still game the system in terms of what they sell you. The claim denials still exist. They can come up with 150 reasons to deny your claim. That doesn't change. Will the premiums go down? No. There's precedent for that statement. They will go up. The 80-85% rule means that the transparency of the private industry now has to come into effect so that they show their books. And the books have to say that depending on the group insured, 80% of the dollars has to go to coverage, or 85%. So what are the insurance companies going to do? They're going to hire a bunch of these young, bright accountants to figure out how to get the numbers to 80-85. And that's probably doable. They're probably going to be able to rearrange their accounting sheets so it doesn't change the bottom line very much. But this is an attempt at regulating a free market. Okay? And if you're the insurance industry, how would you like if you get 15 to 18 new people buying the policies with the government subsidy? You're willing to swallow a lot of crow and put up with all this other stuff for 15 to 18 million new, many healthy customers. So the insurance industry has squawked, but not very loud. You haven't heard much out of those guys the last few weeks or so. The device and the drug industries cut deals. You can read about that in the Wall Street Journal. They cut a deal together, specifically with the president. They sat down and they said, okay, we will pay a fee every year into the public system if you don't touch our business model. Leave us as we are, as a free market enterprise for both the device and the drug industry. So what they came up with is both the drugs and the device industries are going to be paying fees every year into the pot. It's a tax, if you will. But they're not going to have to go negotiate with Medicare on prices of their drugs. That would be the death knell for a free market drug industry. And they can make a lot more money if they keep their ability to price their drugs while they're paying a fee at this end. And the same thing with the device companies. The pacemakers, the hips, the knees, the lenses. So these two industries saw what was coming. They said, we've got to figure out a way to keep our business model as it is, so we're going to pay a tax. And that's what they're going to do. And we're going to see if this really is a significant amount of money or not. Time to tell. All right. So now we get to the end. Will this work? No. No. Am I brilliant? No. I'm average. Always been average. Just average. The health plan that we're talking about was patterned after the Massachusetts health plan in 2006. An individual mandated, employer mandated mandate on the insurance industry. Everybody came to the table, gave a little bit to try to insure everybody, and that's what they did in 2006. And the idea was, with the automobile exchanges, to bring the competition to the private market. You can read worlds about this on Google. But here we are 4 years later, and the track record is dismal. It is so dismal that the private insurance industry filed a federal suit last week because the controller of the Massachusetts state government said they could not raise their fees. And now it's in the court system. Because every year the privates have raised their fees under this system, and that wasn't supposed to happen. And last week it went to court. The court threw out the initial injunction that the private insurance industry wanted and sent them back to the table to negotiate with the state. And we'll see what happens up there in the next few weeks or months. One of the interesting things about this plan, which cannot control costs, which is why it's going to fail. One of the interesting things is who was one of the major supporters of this plan in 2006. It is presumed presidential candidate Mitt Romney. Why do I say that? Because if you go listen to what he's saying publicly now, because this is not doing well, he's trying to distance himself from what is going on in Massachusetts and what is going on at the federal level. So Mitt Romney is really having to backtrack and try to figure out how to nuance his public stance on health care reform. State Senate Bill 2170 in Massachusetts is in the House being considered right now as a mandatory assignment of fee schedule for every single doctor in Massachusetts. It's the initial attempt to control the actual fee schedule of all physicians in an attempt to control cost in the state. So 4 years into this state experiment, it's a disaster because they cannot control costs. And because the federal plan is based on that, it's going to fail unless we can control costs. And here's lessons from the past. No incremental reforms have worked so far. Employer mandates, and there's a whole history of that, hasn't really worked either, to try to control costs. Individual mandates have never really been tried. They've been tried in Massachusetts, but they haven't controlled costs. So nobody has a clue about cost control, and nobody has ever thought much about fairness until they came up with the big bill that we just talked about. I put this slide here about 5 years ago. So people are talking about fairness now, but the elephant in the room is cost. So why would I support a bill that's probably going to fail? What's the alternative? Do nothing? I've been up to my ears in the Cardiology Medical Society trying to figure out an answer to this healthcare nightmare. And if one thing we all agree on is we can't do nothing, we've got to do something. We would accept a Republican plan with all of its problems, just as much as we would accept this plan because it's a start. We have to start somewhere or we're dead ducks. We don't have many years before the Chinese foreclose on us. We really don't, maybe a decade. A single-payer system, I mean a real one, that makes a lot of sense, but the political climate says no. It's a deal killer right off the bat. Republican ideas, we can talk about those at length later on. They don't cover nearly as many people. They have a lot of problems with their plan, namely the idea that, we just make health insurance a free, competitive market and get rid of all the constrictions on it. And my answer to that is, well, that's what we had in 1964, which is why 1965 happened. It's because of the way the insurance industry was before Medicare and Medicaid. So there's a hollow argument in the Republican argument to make a competitive insurance market because that's why we started Medicare and Medicaid. We've talked about fairness, we've talked about sustainability. The new health care bill doesn't get us there. It gets us in the right direction, maybe. It's cost control. I have not talked about rationing. The rationing may come. We hope it doesn't, but it may come. That's the R word. If we get this thing out of courts, it's going to court. The bill is going to court. How do we control costs? This will be my last slide. 2 minutes? Oh, that's actually all right. It turns out cost is me. We're the problem. expense. I'm the one that orders the test. I'm the one that sends the people to surgery. I'm the one that decides to spend the money. And the Medical Society understands this. And we understand that the federal bill has minimum language about cost control because they can't do it. And the state of Massachusetts can't do it, so what they finally decided to do was cap the fees of the doctors, which is a lousy way to do it. How much of what we do is really needed? Probably 2/3. Probably 1/3 of what we do is not really needed. And of course, the doctor's going to say, well, everything I order is needed. But the fact is, across the board, it's probably 1/3. Why? Why is 1/3 unnecessary? It's because you're afraid of getting sued. It's because you're making money off the test. Or it's because you're really thinking you need to do the test. Only 1 out of 3 of those things make sense. The other 2, we've got to do away with. We've got to figure out how to keep docs from ordering tests because they're scared not to order them. And we've got to do away with the concept of making money off of the test. And that is going away. The feds are taking that away from us. The malpractice system, we have to do something to take away the fear of getting sued. That's a big problem. Almost totally ignored in the bill. There's language in there for trial and error, state experiments to work on that. The Medical Society will be heading up an experiment in the state of Colorado. We just tried at the state legislature. The bill failed. It was fought. It was beaten down by the Trial Lawyers Association. But we tried, and we'll try next year. What does the new bill say about all this stuff? Not much. It's on our shoulders. The medical profession has got to come to grips that we drive costs, and we're the ones that have to figure out how to get costs down. We have to change our practice medicine. That's not going to be easy, but it's got to be done. This will be my last slide. Lamb's rule. Some of you know who Lamb was, is. Some of you don't. The Lamb's rule. Any tax-funded system will fail if it cannot limit care. That's rationing. I haven't talked much about rationing. But Governor Dick Lamb said that back in the 70s. And that still may be a true statement. If we're going to extend fairness to the entire room, a subsidized healthcare system, we may in fact have to figure out how to limit care. Incremental reform won't work because you can't do this. There's nothing in the big bill, there's nothing in the Massachusetts bill about rationing. And this is going to be hard. Single-payer system will probably come in one fashion or another. It doesn't mean it's going to be Medicare for all. There's lots of different ways to have a single-payer system and still have it privately delivered. So just because you say single-payer doesn't mean it's going to be English or a Canadian system. And I think this will fail for the reasons we've talked about, and it may end up at the end of the day that Congress can't do this. And we may end up with a constitutional convention in 4 or 5 years, specifically to write an amendment to the Constitution for the building of a national health care system. That's what it may take. Because like I said, this bill is going to court, as they all will. And this I'll leave you with. This is a summary of what we're talking about, how everything is wrong, that we have to figure this out to make health care better. And everybody would agree that the United States really needs to change their health care system to do this. That ain't us, that's Australia. That's a land of a single-payer healthcare system and a parallel private healthcare system. And just because you extend healthcare to everybody, whatever mechanism you do it, doesn't mean you fix it. But making the system fair, having some sort of system that makes sense is the beginning to making a sustainable healthcare system. We're nowhere near that right now. Okay, I'll stop. I'm glad to answer questions if we have any time for that.
Give Dr. Marsh. Well, you can make it to your next class.
When the Medical Society started talking about healthcare reform about 4 years ago, and I was asked to join this task force, we've been at it now, every 8th Saturday for 4 years. We go down there and spend all day on a Saturday hashing this thing out. And one of the big things that's come out of this work is we need one system. And we're nowhere near one healthcare system. We've got 8 or 9 in this country. And that's the fragmentation of the healthcare system, the VA, the TRICARE, Kaiser, the public systems, 2 of those, all the privates, all these different systems. And you try to make heads or tails out of how to control costs with 8 or 9 different systems, all of which are funded differently, behave differently. You can't do it. And that's what the feds are trying to do. They're trying to do this incrementally without tearing down all these systems and creating one. So we're pretty well united that until we're ready to have one healthcare system and everybody's equal, then we can start talking about how to make it fair, how to make it sustainable, how to control costs. But this fragmentation is such it's going to be very difficult. People ask me, why even try this? If all state attempts at incremental reform have failed miserably, why even go through this? And the answer is because for the sake of the country may have to witness this failure. Before the country gets it through its collective head that we've got to change the whole system. There aren't enough people yet willing to give up their Medicare or to give up their TRICARE or their Kaiser. They won't do it. They're afraid of the future. So we have all these silos of people that are doing fine in a system that's falling apart. So maybe the whole country has to witness this thing fail before enough of us get it that we have to join the rest of the Western world and build one health care system. The Dutch have the best. It's the best health care system out there. It's an experiment, but right now it's the best. They had true socialized medicine just like England and Canada, a large degree about 4 or 5 years ago. The Dutch said this ain't working. Too much bureaucracy, too many waiting lists, 2 people dying before they got their heart fixed, so forth and so on. So 4 or 5 years ago, the Dutch said, okay, how do we have a single system that's single payer, based on socialism, but it's privately delivered and it's competitive, which means market forces. So now what you're trying to figure out is how do you have an entitlement coupled with free market forces that actually works. And so they sat down and thought about how do they put these 2 concepts together to build a fair and sustainable system. We got to give the Dutch credit. They kept an ocean off of them for 1,000 years. You got to say these people are clever. And you got to pay attention to them. If they can keep water off of them that long, pretty smart people. And actually Venice has them down there now trying to figure out how to keep the water out of Venice. So what they came up with is, okay, it's one system, everybody gets the same health insurance policy. Okay? If you make nothing, we're going to buy the policy for you with tax dollars. If you make $30,000, we're going to pay some. If you make $50,000, we're going to pay less. If you make $100,000, you're going to buy the same policy with your own money. So it's a de-escalation of subsidy as your income increases, but it's the same policy. So they have a general tax fund, they have an income tax, graduated income tax, all of which goes into the healthcare system. And that's how it's funded. And there the government gets out of the way. And the government set up an independent commission, much like the one I talked about, to run the system. And that system then becomes, that governing group becomes the judges to maintain a level playing field between the insurance companies, of which there's 6 or 7 in Iowa. The insurance companies all compete among each other to deliver the same policies to anybody that wants them. You get on the phone, you give your social security number, and you're enrolled. And you can do that every year. You can change the company once a year. Each company competes not so much on price, because they can't vary the price within the company. Whatever you sell that policy for, you sell at the same price to everybody. Price can vary from company to company. Turns out they don't vary that much. And then what happens is the insurance companies realize they're not going to make a lot of money on the health policies. But they've got these people in the door to sell life, auto, disability. You see? They're not stupid. Sell them something else. So the health insurance industry in Holland hasn't squawked too much about the price controls and the fact that they have to give everybody the same policy. And then what the insurance companies do is they turn around and contract with NCMC. One big chunk of money per year. And out of that chunk of money, NCMC pays all the people on its staff, including me. So I don't send a bill to anybody. And the hospital doesn't send a bill to anybody. There is no bill. So you have a contract with this insurance company, maybe another with that insurance company. You revisit the contract every year. It's competitive. The hospital is competing on service and quality and how the patients like it. And they're also competing on how they can do things for a certain amount of money. And that's how they have put competition into a socialized healthcare system. The insurance companies compete, the docs and the hospitals compete among themselves, and there's this regulated market. And that's what the Dutch have come up with as their best experiment to get pure socialism out of the delivery system, but keep it in the finance.
And is there malpractice? Are you allowed to sue doctors?
Yes.
I was in Germany for 15 years. And
Yeah.
suing doctors is virtually non-existent.
Right. And in Holland, it happens, but very few get to court. Because the way it works in Holland is they got mandatory arbitration that actually occurs within the offending institution. So the way they build their malpractice system, and we're actually looking at this, is somebody is injured within the environment of an institution. The environment is expected, the institution is expected to take ownership of that and become the patient's advocate, as opposed to adversary, which is what happens in medical malpractice. Now, if I get sued and my attorney says, shut up, stay away from the patient. And it's exactly flip-flopped in Holland. Go to the patient, we're sorry, we screwed up, we're going to take care of your bills, we're going to improve that doctor, we're going to do as best we can for you. That's how they handle it. And in fact, that's probably what's going to have to happen in this country.
And the trial lawyers aren't making any money.
Well, it turns out,
In Holland.
it turns out that the injured patient in Holland is more than welcome to bring an attorney with them to the table to advise them on what we're telling them. So there is total transparency, nothing is withheld. And then if the offending institution can't make it right, then it goes to court. But by doing that, and the two biggest pieces in this country that have emulated the Dutch medical malpractice system, University of Illinois, and I think the University of Chicago, they have now taken a total flip-flop in medical malpractice and say, if we injure the patient, we take ownership of that within 15 minutes, and we're going to be the patient's advocate. And it's dramatically cut back to the lawsuits. So there is a way to get out of this mess, but it may have nothing to do with the legal profession, which is interesting. But there is, and I'm on that task force also, and that's one of the things we try to push to the legislature this time with trial lawyers. It's a new concept for them, so obviously they say they don't want it. But we'll do that. So we'll see what happens. So the rest of the country, the rest of the world has problems. But at least they live in systems where there's sanity and fairness in one system. We're so fragmented and unfair that we have lunacy existing, and we're trying to incrementally fix this lunacy. It ain't going to work unless we can control costs. So stay tuned. Thanks for your time. Go ahead.
Well, how do doctors feel about getting a salary rather than an individual pay for service?
The old ways are over. Get over it. And personally, we saw this coming 5 years ago. For years and years, my group did not want to have their own treadmills and echo machines because there was a conflict of interest. Every time if we bought a machine in order to test on that machine, we got paid twice. We got paid for looking at the test, and we got paid for doing the test. That bothered us. And we didn't want that, so for years and years we said we don't want to get in the business of owning our equipment. There's a conflict of interest. And about the year 2000, we said we don't have a choice. We don't make enough money to bring in new people. We got to make more money, and the way to do that is to go buy equipment. So we did that up until about 2005. We made more money, but we still couldn't make enough to bring in young people who can make a lot more in Georgia or Texas or Florida. All right? 2004, 2005, we would sit around the table at our business meetings. We would say, you know, we're beating our brains out here, trying to make enough money to attract young people, and we can't do it. And in the process of ordering tests, we're not really sure need to be done. We don't like this. So we sat and looked at each other and said, there's no future in this. Private practice as a cardiologist is over. You can't do it, keep your sense of ethics, and have a successful practice. You just can't do it. So we sat down at the hospital, Banner Health, and we said, we get it. We want to start over, we want a new model, we want to be employed, get rid of our equipment, pay us a salary, and pay us on quality. If we do our jobs right, we get paid. If we do our jobs badly, you're going to get rid of it. So that model is what we took on about 4 years ago. The rest of the cardiology groups in the Front Range will emulate that in the next 18 months because the feds have taken away all that money. All the money we used to make off the machines, gone as of January 1st. So all that income that we used to get is no longer going to be there. So virtually every big cardiology group on the Front Range and in the United States is now actively seeking the entire new model of practicing. Does it bother me? No, because Europe taught us 20 years ago, this is what we were going to be. And here we are, get over it. This is how the world is now. You guys cannot afford for me to go back and practice another model. You can't. And you know it. And everybody's going to emulate that over time. And then it makes things easier because now, if we ever get to contracting and get away from fee-for-service, which we also think is the future, the contracting has to be a simple contract, not 100,000 contracts. So you have a great big deliverer of health care like Banner, who can now sign one big, honking contract with Medicare. Imagine the efficiency. That's where we think the thing is going to go. And this all may happen in spite of it. And in fact, there's a group of us that think the feds can't do it. We got to start at the bottom and work it back up to the top, which is what the Medical Society is doing. We're now scratching our heads saying, okay, we've got to figure out how to get a state experiment going to get away from fee-for-service. And that's our next goal. And where we go with that, I don't know yet, but that's on the table, is we have to get the state away from fee-for-service and change the model of the business. But you're right, you're absolutely right. Thanks for coming.
Thank you.